Bonjour à tous. Nous allons reprendre la troisième session qui est consacrée aux épidémies. Je suis Steve WaCA de la RDC et je suis très content de co-modérer cette session avec mon collègue et ami Yap Boum. Nous allons parler des épidémies à travers le monde, mais particulièrement dans le continent africain. Nous parlerons des épidémies qui sont un peu plus médiatisées à travers les médias, des épidémies un peu plus intéressées, mais aussi de celles dont on parle très peu, qui sont pourtant très importantes, et un peu ça à l'image des MSF qui essayent d'associer l'urgence aux maladies dont on ne parle pas beaucoup. Et parmi ces maladies dont on ne parle pas beaucoup, il y a la première présentation qui portera sur la diphtérie, qui est une maladie éteinte par la vaccination, mais qui continue à faire des épidémies, et parfois c'est épidémies qui restent parfois silencieuses et non connues. Et c'est à ce titre que Jonathan Polonsky va nous faire une mise à jour de cette épidémie à travers un pays africain que vous allez découvrir. Et Jonathan Polonsky, c'est un excellent épidémiologiste qui a une grande expérience de plus d'une vingtaine d'années dans le domaine des maladies infectieuses et de l'information sanitaire humanitaire, notamment en matière d'évaluation rapide des surveillances et des réponses aux épidémies. Il travaille régulièrement pour MSF et Epicentre depuis une vingtaine d'années et a passé 10 ans au sein du programme d'urgence de l'OMS, principalement dans le domaine de la surveillance et de la réponse aux épidémies. Jonathan, you have the floor.
Merci. Good morning, everybody. I'm here to talk about two studies that we've done. In total, it's a retrospective study of the diphtheria outbreak that occurred throughout West Africa, but specifically in Kano State in Nigeria from 2023 to 2024. So, since 2023, there's been a multi-country diphtheria outbreak in many countries in West Africa, including Nigeria, Guinea, Niger, Cameroon, and Gabon. Nigeria has been the worst affected, with approximately 26,000 confirmed cases across 26 states from January 2023 through to March of this year. Kano State has been the epicenter within Nigeria, with over 18,000 confirmed cases and 850 deaths. And within Kano State, the highest number of cases have occurred in Kano City, and facility data suggested an attack rate peak of over 500 per 100,000 population, which equates to about 0.5%, specifically in Ungogo, Fagi, Nasarawa, and Dawa Kintofa local government areas. And those 4 LGAs are where we conducted our studies. So MSF Western Central Africa played a prominent role supporting all pillars of the response, primarily in case management, and they established diphtheria treatment centers where they administered diphtheria antitoxin, gave antibiotics, performed airway management and supportive care to patients, but they were also involved in infection prevention and control, vaccination, surveillance and epi, and risk communication and community engagement. During the peak, a number of cases went from about 100 per week through to close to 800 per week, and there was insufficient diphtheria treatment center capacity to cope with this. And so MSF WaCA developed and implemented a novel home-based care strategy to reduce pressure on the DTCs. And what this looked like was at triage, any mild patients who presented during this period where you see the green arrow were provided with oral antibiotics and discharged. They were followed up at days 3 and 7, and there was a weekly outpatient department visit. If at week 3 there was no deterioration, the patients were vaccinated and discharged. And between January of 2023 and March 2024, MSF WaCA treated approximately 15,000 patients, 8,000 in diphtheria treatment centers, which you see in light gray at the bottom, and 6,700 in home-based care, which is the darker bars. So our study objectives were, firstly, to describe the impact of the outbreak in terms of the attack rate and case fatality ratio, to explore the impact of care-seeking behavior on mortality, and to evaluate this novel home-based care strategy, which was again used for mild cases. And we looked at mortality, specifically case fatality ratio. We assessed the acceptability and perceived quality of care that was given, long-term sequelae among survivors, and within household secondary attack rates, which is defined as any secondary case within 30 days of the onset of disease among the primary cases. So we had two studies that ran in parallel. For the impact of the outbreak, we did a population-based retrospective mortality and morbidity household survey. We used spatial sampling with 65 clusters of approximately 15 households each, and the recall period was from January the 1st, 23 through to the survey date, which ran somewhere in September, October 2024, approximately 631 days. For the home-based care strategy, we performed a matched retrospective cohort study of mild diphtheria cases. We matched on age group within 5-year bands, sex, vaccination status, and geographic location. And for sampling, we used, as a sampling frame, MSF WaCA's patient registries. So for the household survey, where we were looking at the impact of the outbreak, we recruited close to 8,000 study subjects. 88 community cases of diphtheria were detected. These were not confirmed, but these were using a community case definition. This gave us a crude attack rate of just over 1%, which is approximately 2 times the highest pre-study estimates based on passive facility data. It was highest in children aged 6 to 10 years, at about double that. And for mortality, we detected 110 deaths, 59 of whom were among under 5s. And diphtheria accounted for 7.3% of all deaths detected, and this was actually 10% among the under 5s, so quite a high proportion. Case fatality was 9% overall, and double that among the under 5s. And for risk factors, we found that age was a major risk factor, with a mortality rate ratio among the under 5s of 8.6 compared to the over 5s. Vaccination status, with a mortality rate ratio of 2.3 among the unvaccinated compared to the vaccinated. And care-seeking behavior was a very important risk factor. And we found that mortality was 40% lower among those who sought any care at all, and was 17 times higher among those with delayed care seeking, among those who did seek care. And this was defined as seeking care after 3 days or more from onset of disease. Looking at the home-based care strategy, where we did the cohort study, we recruited 678 patients, 367 in home-based care and 311 from diphtheria treatment centers. Remember, these were just mild patients, so the case fatality ratio was 3.6 overall, 1.9% by home-based care, and 5.5% according to diphtheria treatment center. So we found no evidence of higher mortality by home-based care, but of course we found higher mortality by, within the diphtheria treatment centers, which we dug into the data a bit further. We found this was likely due to confounding by severity. So even though we were only meant to be looking at mild patients, we did find that there was some evidence that this severity variable was not very well recorded in the database, and we found some patients with complications recorded, and that should have excluded them. When we removed these patients from the analysis, we found there was no difference between the two arms. There's very high acceptability. Out of an average score out of 5, it was 4.7 by home-based care, 4.8 diphtheria treatment centers, so very high in both groups. For long-term sequelae, 2.1% overall. It was mostly minor or short-term, no difference by treatment group, but it was strongly associated with complications, with an odds ratio of 30 among those who had complications. And again, secondary attack rate was 4.2% overall, so 4.2% of close household contacts of primary cases became secondary cases themselves. There was weak evidence of a higher secondary attack rate in diphtheria treatment centers. at 1.5, the secondary attack rate ratio, but it was much higher, again, among patients with complications, so a secondary attack rate ratio of 6.1. So this was a high-impact epidemic with a high attack rate affecting up to 2% of the population in the worst affected areas, and this was between 2 and 4 times higher than the facility data implied. And this suggests that there was a large number of undetected community cases that never presented at facilities. Diphtheria accounted for a substantial proportion of all-cause mortality, and there was high case fatality ratio, particularly among the under 5s. We also found that early care seeking was strongly protective against mortality. Care seeking at all, but specifically early care seeking. And for the home-based care strategy, we found no evidence of worse outcomes in home-based care compared to DTCs in terms of mortality, sequelae, or secondary attack rate, and both were equally well accepted. So again, this was a high-impact epidemic with high attack rate and mortality. A relatively small proportion of cases were passively detected through facilities, and this suggests a need to reinforce community surveillance, including active case finding and contact tracing, and early care pathways to ensure earlier and greater treatment coverage, and therefore better outcomes for the patients. And in conclusion, we found that home-based care can be a safe, effective, and acceptable strategy for mild cases in outbreak settings where there's limited bed capacity, noting that most diphtheria cases are non-severe and would be appropriate for home management, and home-based care has the potential to increase access to healthcare and shorten treatment delays. And I'd just like to end by thanking and acknowledging the work of colleagues in the field, in particular staff at MSF West and Central Africa, Suleiman Hudu and Khadija Utman in Kano, and Frank Allais in Abidjan, but also our colleagues at the Kano State Ministry of Health, Nigeria CDC, and Etienne at Epicentre. Thank you very much.
Thank you so much, John, for the great presentations. Good morning, everyone. So thank you, Claudia and the team, for giving me the privilege to moderate this session. So the second presentation on the multidimensional study of the epidemiology and prevention practice of MPOX in Budjala Health Zone in DRC will be presented by Sophie Meakin and Cheick Oumar Doumbia. So Sophie is an epidemiologist with a strong background in statistical and mathematical modeling infectious disease, and we will be well combined with Dr. Cheick Oumar Doumbia, who is also an epidemiologist, who has been the referent for research for WaCA. So the floor is yours.
Thanks so much for the introduction. So yes, today we're going to talk about the TRACK-MPOX study, which is a multidimensional epidemiology and community response to MPOX in Budjala in the Democratic Republic of the Congo. Okay. So as I'm sure many of you are all aware, MPOX is a viral zoonotic disease which has a very high burden in the DRC. There are 2 subclades currently circulating in the country, clade 1A, which is endemic in many central and western provinces, and new clade 1B, which emerged in September 2023 and has since caused widespread outbreaks in the east of the country in many previously unaffected regions. So while MPOX is certainly not new to the country, there has been a year-on-year increase in the number of reported cases in recent years, from approximately 14,000 suspected cases in 2023 to more than 40,000 suspected cases in 2024. In Souda province, which is in the north-west of the country, where clade 1A is endemic, is among the top 5 most affected provinces in the country. So in June 2024, MSF West and Central Africa launched an emergency response in Budjala Health Zone, which was the epicenter of the outbreak in Souda province. And support there included case management, epidemiological surveillance, and operational research. So the motivation for carrying out research in this setting is that, especially compared to clade 1B in the east of the country, there are fewer recent studies on clade 1A in endemic settings. So a real need to understand both the true burden of MPOX in these endemic regions, but also perhaps what is driving transmission and the increase in number of cases. So the overall aim of the TRACK-MPOX study was to describe the epidemiology of MPOX clade 1A in Sudu-Bangui with specific objectives including describing the demographic, epidemiological and clinical characteristics of cases, identifying risk factors for disease and severe illness, and estimating the attack rate among the general population. So there are a number of activities that we carried out in order to answer some of these questions, which we're just going to focus on 2 of them today. So the first activity was cross-sectional survey of cases, where we conducted interviews with MPOX cases identified in Budjala Centre Health area between January and December 2024. And the second activity was a multidimensional household survey in Budjala Health Zone, asking questions about MPOX incidence, mortality, vaccination between January 2024 and the interview date in April 2025. So I'll now present some results from these 2 activities. So first, some results about the interviews with cases in Budjala Centre Health area. So 527 people were interviewed during this part, of which approximately half were female and 65% less than 15 years old. The characteristic rash and lesions characteristic of MPOX were reported by all cases and were most commonly reported on the face, torso, arms and legs. The extent of the rash varied, ranging from localized to just a small area of the body, such as arms only or legs only, to widespread rash. And 16% of cases reported this widespread rash, which we defined as affecting 5 or more areas of the body out of 7 total. Through univariate logistic regression, we found that although there was no difference in the likelihood of reporting widespread rash according to sex or age, it was most commonly reported among some specific symptoms, namely swollen lymph nodes, sore throat, difficulty swallowing, loss of appetite, and fatigue. In terms of severity, 17% of cases were hospitalized with a median length of stay of 8 days, and this was significantly more likely among people who reported these widespread lesions. 4 individuals reported long-term ocular complications, although no deaths were reported among this particular population. Finally, in terms of transmission, 42 cases, or 8%, reported at least 1 or more additional cases in their household, and children less than 5 years were much more likely than adults to report illness when in a household with another MPOX case.
I will now present the data from our household survey. We surveyed a total of 1,438 households, reaching all the 17 health areas of Budjala Health Zone, with a very few refusal rate. Most of the households were large, averaging about 6 people per household. The most occupation reported during this survey was farming. From an epidemiological standpoint, we have an overall attack rate of 2.0% in the household, in the health zone, and with a high transmission in the northern part of the health zone. Household size played a role in the transmission. Among all of the MPOX cases we found during this interview, nearly 80% of them live in the household with a size above 5 individuals per household. So we also found that children under 15 years old represent two-thirds of all the MPOX cases found in the survey. Also, we noticed that there was a vaccination campaign which was organized by the Minister of Health to control MPOX disease. So this vaccination include MVA-BN vaccine and targeted individuals above 18 years old, and also the high-risk population, including healthcare workers, the contact of cases. So we found that the coverage of this vaccination was only 17% in all the health zone. So from January 2024 to the interview dates, as a recall period, we found a crude mortality rate of 2.1 per 10,000 per day per person. So also we try to investigate about the number of cases. So we found that only 4 deaths in this study among MPOX cases, which is corresponding to 2.1% of case fatality rate. While analyzing for the risk factor closely, we found that the strong predictor of MPOX in this population was having another MPOX in the household. This population have a 7-time order ratio, increase order of order ratio, compared to those who don't have any MPOX case in their household. So also age matter. Individual above 15 years old had and half likelihood to get MPOX compared to children under 15 years old. So also we found that the crowding of households also was associated with MPOX, specifically people living in a household with the size above 5 have 70% increase order of MPOX compared to those living in smaller household. So here we, after adjusting in the multivariable model, we did not find any association between MPOX and sex, occupation, and the density of area. So to conclude these 2 pillars of our study, so we could say that the burden of MPOX in this health zone was higher, and then we found also that many of people sought care, which is a strong indicator for community responsiveness and also for care-seeking behavior. This is a good indicator which you'll find. Only 17% of individuals who went to hospital got hospitalized during this survey. And then we realized also that the main risk factor for MPOX are age and the size of household. So which are the main driver of MPOX transmission in this community. So we would like to thank all our collaborator partners from MSF WaCA, from Epicentre and University of Kinshasa, and the Minister of Health with the DPS, Division Provinciale de la Santé de Sud-Ubangi. Thank you all for your attention.
Thank you, Sophie. Thank you, Cheick. So I believe that we have 10 more minutes. We started a bit late. So as you know, we are dealing with multiple MPOX outbreaks. So this was mainly the one due to the clade 1A, and when we move to the next presentation, that will be done by Isidro on the MPOX clade 1B epidemiologic highlight from the Uvira outbreak in South Kivu, DRC.
Good morning, and thank you for the presentation. I'll try to be very quick. As Sophie and Cheick have already provided an epidemiological overview of MPOX in DRC, I will dive directly into this very brief presentation, which is about the epidemiological highlights from this MPOX clade 1B outbreak in Uvira, in DRC. So first of all, a bit of context. Uvira is a health zone that is mostly urban. 400,000 people live in that health zone, most of them in the city. It's a crossroad between countries. You can see in the map there that it is in the border with Burundi. It's very close to the border with Rwanda, and is sitting on the shore of Lake Tanganyika, which provides direct communication with Tanzania and Zambia. It's a conflict-affected area. There are many IDPs and refugees living in the city of Uvira. Very important as well, Kamituga, which is the first area where the clade 1B was identified. It's also in South Kivu, so it's relatively close to Uvira. The first cases of MPOX were reported at the beginning of May 2024, and MSF WaCA started supporting response activities in June 2024 until March 2025. In terms of methods, we used the MOH case definition. We included all the cases who visited our supported facilities. Samples were tested with qPCR. We used MSF line list to collect data, and we calculated frequencies and percentages for the main indicators. So now, for main indicators, we saw 4,614 cases. 20% of all of them were tested. Among those tested, 60% were positive, so we had a positivity rate of 60. The median between symptom onset and presentation was 4 days. 28% of all cases visiting the facilities were admitted. For those cases admitted, the median length of stay was 5 days. We had a total of 8 deaths, which brings us to a case fatality rate of 0.2%. And very important, 5 out of these 8 deaths were in children under 1 year. So this is a case fatality rate for that group of 1%. In terms of weekly trends, we can see in this B curve here that the number of cases remain very high for many weeks. Also interesting, the OPD, the percentage of OPD cases increased a bit over time. As we speak, they're still seeing cases in Uvira, around 30-20 cases per week, but MSF handed over activities at the end of March, as I said. In terms of age and sex, in this pyramid, we can see that the most affected age group was children. Under 15 years old were 62% of all cases. Under 5 years old, were like 33% of cases. Just to put into context, there are 17% of children under 5 years in the overall population of Uvira. So this is almost that figure, almost double that figure. Very interesting as well is the change in the percentage of under 15 years over time. We can see that the most affected age group changed from adults to children within a few weeks. At the beginning, most of the cases were adults, sex workers, traders, business people with recent history of travel, but that changed to children. That makes us think that the way the disease arrived into Uvira was via sexual transmission, but then this changed and the disease established itself in Uvira via non-sexual transmission. And And on that line, we can see that the most reported type of contact was indirect contact, meaning that the person was in close proximity, but without having physical contact with the case, followed by physical contact. And sexual contact was reported by very few cases. Also very interesting that the most reported location of contact was the household. At this point, we have to keep in mind that one of the distinctive characteristics of the clade 1b is that transmission is exclusively from human to human, as opposed to 1a, where zoonotic transmission plays a very important role. We thought at the beginning, or the reports were saying that the most important transmission for 1b was sexual transmission, but that's not what we saw overall here in Uvira. So in conclusion, this was an analysis from a large case series of MPOX patients infected with the novel 1b clade. This is a changing and a diverse epidemiological profile in the sense that the most affected age group and the most common route of transmission changed over time. Also, some of the epidemiological aspects from these outbreaks are different to what have been reported in other areas of South Kivu. Transmission was mostly in households via non-sexual contact. The most affected group was children under 5 years old. Very important, mortality was concentrated under 1 year old. Despite the relatively low severity and mortality, there were many cases, and the outbreak is still ongoing, and this supposes a huge burden for an already overwhelmed healthcare system. And with that, I finish. I would like to acknowledge all the colleagues from different institutions who participated in this piece of work, especially Elvis and Steph, who were the project epidemiologists who did most of this work, but they cannot be here presenting today. So, thanks, everyone.
Merci beaucoup, Isidro. Maintenant, nous avons 10 minutes de questions et vous avez la parole. Oui.
Thank you so much for the presentation. I have one question for the diphtheria. We know the home-based care is where to go, and it's a good method. And we have applied also in Nigeria in my degree project. But I have one question. It's quite challenging, and it has a lot of challenges associated with, like the issue of the strict isolations, the issue of the contamination, and also psychosocial impact, like the stigma. What was the most prominent challenges that you have faced with the home-based care? Thank you. In Kano.
Merci.
And my name is Abdulwahab Mohammed. I'm the MEDCO for Pakistan. Thank you.
Okay. On prend une série de 3 questions pour gérer les temps. Une autre question?
I've got a question. So mine is on the second presentation about MPOX 1A. I was wondering if for risk factors you looked at like routes of transmission, specifically animal contact, especially for kids, and then which type of animals, if you did.
Troisième question, physique, avant qu'on prenne les questions en ligne. Une dernière question. Sinon, on répond aux 2 premières questions. Ensuite, oui, en ligne, oui.
So there is one question from Tambe Elvis. Thanks for the excellent presentation. Question on diphtheria in Nigeria. What was the DPT vaccination status among cases and its impact on outcome? You mentioned higher CFR in non-MMR vaccinated children. Was vaccinated, in bracket, defined as 2 MMR doses?
Okay. Thank you. Okay. First question, thank you very much. And it's interesting, it's great to hear that it's been considered in other settings as well, home-based care. I was not there. I mean, it's a shame not to have somebody from WaCA able to respond directly who had experience in Kano. But from what I understand, it was exactly the elements that you raised. A lot of challenges with the infection prevention control within a household. And as we saw, there was some secondary transmission within households, and that was one of the major concerns. And so it was a big relief to find that there was actually no difference between that and the diphtheria treatment center. And also, as you said, the impact on mental health and psychosocial, the burden from that was enormous in the population, primarily among, of course, family members who lost loved ones, and we had some awful stories told to us. But I think the main takeaway is this was the first time it's been implemented. It was very novel and innovative, and it was answering to a major constraint that the team were facing. And I think iteratively we can improve and we can learn from that experience. I don't think it was by any means perfect, these aspects that you highlighted, but I think it gives us a lot of encouragement that we weren't on the wrong track by going down this route. And the second question was on the vaccination. I didn't fully get it. It wasn't MMR vaccination. I'm not sure that came across, but it was pentavalent, I think. There were two vaccines that were given, and what we found was, okay, with the odds of mortality among vaccinated was much, much lower, but then we did find some sort of slightly confusing results when you looked at the odds of being a case, and there was clearly some confounding based on the timing of the vaccination, because as you saw, the protocol was that patients were vaccinated on discharge, and capturing that variable, the timing of the vaccination, was a little bit complicated in the survey. So there was some confounding, and sometimes it actually looked like vaccination led to higher odds of being a case, which obviously we don't believe to be a correct finding.
So I'll respond to the question about animal contact. So we did ask in all the components of the study, we did ask some questions about contact with animals. For the two parts that we showed here, so A, which was the first part, which is the interviews, we did ask some questions, somewhat limited by the fact that these interviews obviously happened quite a long time after the exposure sort of might have happened, and is also self-reporting, and similar for C. The part that we didn't talk about today, where we sort of prospectively enrolled new cases and followed up with them in their households and asked similar questions. Analysis is still ongoing for that, so we're hoping that will perhaps have some more complete or more reliable information. So kind of wait and see.
On a encore 4 minutes. Il y a des questions. On va en prendre 2. Oui.
Thank you. So I'm Monica. I'm working with the access team now in MSF. One of the big constraints on the diphtheria outbreak response was the lack of availability of DAT, and that may have an impact on what is the operational strategy chosen for that. And I know maybe that's not the right forum to ask the question, and you may not have the answer, but how do you see that having access to available treatment may or may not have impact either the outbreak, or in your study, did you have a stratification of patients that would have benefited for early access to DAT, and then they didn't, and therefore they have an impact on mortality? Thanks.
Dernière question. Une question en ligne.
So the question online is also on the diphtheria. It's Muhammad, was asking, what's the definition of CFR for home-based care? Is it those who died at home, or those who started the home-based care but became critical and sent to the hospital? And then Frank Allais, who is currently at the WaCA board retreat, is congratulating the colleague for the nice presentation.
Thank you. Hello, Frank. The first question, yes, on the diphtheria antitoxin, I think there are maybe some colleagues in the room who have actually looked specifically at that. That was not something that we were looking at, but it is clearly an issue that there's a limited global stockpile of diphtheria antitoxin. I also was involved in the very large outbreak among the Rohingya population in Cox's Bazar in Bangladesh in 2017. And that was one of the major constraints, and one of the major tasks as epidemiologists was to forecast, and I think Flavio also was very involved in that at the London School, forecasting the requirements, because that is a really difficult thing, because as you saw, Nigeria was one outbreak out of at least 5, and in fact there were also outbreaks ongoing in other countries as well. The same was true in Bangladesh. There were at least 4 very large outbreaks, and you're kind of competing when you're ordering. And in fact, I think there was some evidence that there was even some withholding of that even when it was in hand, because just in case you see more severe patients later on. That is the Bangladesh context. For Nigeria, I suspect it's exactly the same. We really need to advocate for greater production of diphtheria antitoxin, because it is a major lifesaver. Diphtheria case fatality without diphtheria antitoxin is at least 10%, and it's much, much lower if with prompt administration of DAT. So thanks for making the point. For case fatality, the definition was the latter. If they started on, so they would have started as mild patients at the triage. If they then became a severe patient, they were included initially as mild. But that is actually a very good point, and it's something that perhaps we should dig into more further to make sure that they, it was a sort of intention to treat analysis. So whatever they ended up being, it was kept in that way. Thank you.
Merci beaucoup, Jonathan. Donc, avant de laisser à mon collègue Yap de conclure, donc je voudrais remercier MSF Epicentre de m'associer toujours à cette journée scientifique assez intéressante. Et vous voyez ces mélanges entre les épidémies qui sont connues, médiatisées, et celles dont on parle peu, comme la diphtérie. Rien que l'intérêt des questions montre qu'on doit aussi nous intéresser à ces épidémies qui causent parfois même beaucoup plus de dégâts que celles qui sont médiatisées. Donc pour ça, je passe la parole à Yap.
Thank you so much, Steve. So thanks really for the great presentation. So what we learn and that we know is from diphtheria, you highlight that the home-based care, as the colleague was mentioning, is really one key opportunities from diphtheria, but also which can be implemented and used for MPOX. But there are quite a number of challenges in terms of what you mentioned, the IPC and so on. So as we do speak right now, MPOX is not over, so it's important to find out what MSF will continue to do. At the time where the public health emergency was declared, there were 13 African countries affected. Now we have 20 of them. At the time we were dealing with the clade 1E and clade 1B. Now we have the 2B escalating in West Africa, with Sierra Leone, with now Togo having some cases, Ethiopia also. So it's critical to see how we can learn from those experiences and to take advantage of the role of MSF, which has a unique opportunity to push and to work with all the other partners in the response to those outbreaks. So that was also my advocacy piece, sorry. And at this point of time, we lack vaccine. It has not been mentioned during the presentation, but currently the country are in need of vaccine. The need is around 6.4 million doses of vaccine by the end of August. Currently, as we do speak, there is none that is available, nor funded, so it's also an opportunity to make that advocacy. So thank you again for the invitation, and then we can clap for our speakers. Thank you.